hit the record button. Thank you all for joining in today. I can't think of a better time to talk about addictions than the start of the new year when we're all making different resolutions, and most of us seem to fall off of them pretty quickly. Um, one of the things that is really adding to this certainly is stress and COVID. And in fact, CAMH has actually shown that stress levels have doubled since the onset of this pandemic, doubled. And 50% of Canadians report worsening of their mental health, and 44% report feeling anxious all the time. And that's according to Mental Health Canada. And it's not just our mental well-being, because 25% of Canadians between the ages of 35 and 54, and 21% of those aged 18 to 34 have significantly increased their alcohol consumption since the start of social distancing. And as we know as practitioners, when we ask a patient, how many glasses of wine do you have or alcoholic drinks per week, and they say 6, we can pretty much put 9 in our chart. So this number truly is underestimated, I believe. And it's also one that is, these are only the numbers that people are, quote, admitting to. But what's even scarier is that 47%, so almost 50% of adults admit to overeating. And the biggest part here is that there's the inability to stop and this eating, and this is since COVID started. And it's this inability to stop, which is what starts us down that addictive road. Now, COVID certainly did not start all of this, because even before the statistics show that 20% of people will experience an addiction during their lifetime. 1 in 20 Canadians are food addicts. Almost a third of North Americans compulsively eat. And 20% of Canadians have an addiction to alcohol or heavy drinkers. And those who smoke cannabis daily are 50% more likely to develop another addiction. So it's not just COVID, but COVID certainly has augmented these numbers, and we'll see why with respect to stress. Now, there's a lot of other kind of addictions that we know as well. Exercise, shopping, work, sex, pornography, internet surfing, gambling, all these sort of things. And although we may think of one form of exercise as or one form of addiction is better than the other, so exercise is better than, say, cocaine addiction for sure, the pathology behind it is still the same. And if we don't get at all the different versions of pathology behind this, we're really not going to get to the root cause of the addiction, and we're going to end up trading one addiction for another addiction. And this is why I love genetics, because it allows us to see all the different variables that may come into play with respect to addictions. So to fully understand what's going on with addictions, we need to look at the pathophysiology behind it. So this whole cycle begins in the VTA, or the ventral tegmental area. And the VTA serves as this interface between emotion, motivation, and action. And it's based on numerous inputs from the amygdala, prefrontal cortex, and hippocampus. The amygdala connects internal and external sensations to emotion, and then sends that down to the nucleus accumbens. Then the hippocampus is responsible for the memory of that sensation, while the prefrontal cortex orchestrates higher decision-making and planning as to how to get that stimuli, that addictive substance next time, or not to get it. So let's put this into an example to make it a little easier to understand. Initially, the VTA will see or smell or even just think about something, let's say like a piece of cake. These thoughts of the cake alone can stimulate the release of dopamine. That dopamine is sent down the mesolimbic pathways to the nucleus accumbens via the amygdala, who coordinates things like, how great does that cake smell? How gooey might it be inside? How warm is that piece of cake? All those different sensory qualities. Then the hippocampus pipes in with information like, how great did that cake taste last time I ate it? And how long did those good feelings last after I ate that piece of cake? And then the prefrontal cortex synthesizes all sides of those equations and essentially decides, should I go after that piece of cake or should I not? Is it worth it or is it not? And if it's worth it, it then stimulates food-seeking behavior to go get that piece of cake. That food-seeking behavior alone, not even getting the cake, but the bigger part of dopamine release in the VTA is that food-seeking behavior. But unfortunately, it then goes down that mesolimbic pathway again into the nucleus accumbens, and around and around and around goes this loop until we're in this cycle of, I have to have this piece of cake, I have to have it again, and I have to have it again. So let's take a look at some of the key hormonal players that are involved in this. And these are the ones that we can help our patients moderate so we can help their addictions. Well, dopamine, as we know, obviously, it's our reward chemical messenger. And it has the ability to neuroadapt or alter and psychostimulate reward. And as we just saw, even the thought of or sight of an addictive substance, such as that piece of cake, increases dopamine release. But it also has the ability to alter dopamine transmission, ultimately increasing appetite and increasing food seeking behavior. And what other hormone do we think about with food seeking behavior? Well, ghrelin, of course, and with good reason, because ghrelin augments the frequency and the patterns of action potentials generated by dopamine cells in the VTA, which further augments the food seeking behavior of dopamine. And this is particularly true with ghrelin's nemesis foods, saturated fats, and sweets. So there's this double effect, if you will, with ghrelin and dopamine together when consuming these foods on a regular basis. It lays the foundation for food conditioning, high emotional reward from it, and thus addiction. So, what are some of these genes that we're looking at when we talk about dopamine? Well, DRD2, of course. This is the dopamine receptor and the production of dopamine itself. Number of receptors that we have is dictated by our alleles here. The A allele is the normal allele, which has a larger proportion of dopamine production and receptors. The G is the variant, which has far fewer. It's also really important to note that there's a lot of dopamine receptors, not just through the VTA, but also a lot in the kidneys, which codes for alterations in the renin-angiotensin system, increasing bloating, edema, and altering blood pressure. So really important to keep an eye on patients, again, who have addictive behaviors with edema, bloating, and blood pressure, because it's generally coming through here. So what do we see with the G allele, the variant allele? Reduced number of receptors, decreased pleasure derived from everyday event, frequent need for exciting, stimulating behavior, of course, increased addictions, increased interaction of all of these effects when FTO and MC4R are also variant because they have issues with ghrelin. We have increased cravings for those dopamine foods, the cheese, the nuts, the wine, the chips, and of course, increased focus, concentration, and thus ADD, ADHD. DRD2, ANC1, pretty much almost identical to DRD2, except for the alleles are the reversed. The normal is G this time, and the variant is A. This gene is also, along with DRD2, involved in a lot of the Parkinsonian type symptoms and demyelination disorders. And again, what are we going to see here? The exact same characteristics as we saw with DRD2. We're going to see these with ANC1. Then we have COMT, of course. COMT talks about how quickly we clear out dopamine, also how quickly we clear out our stress hormones. And so this is and estrogens as well. This is really important because we see there's a dual effect here of being normal or being variant. If you're normal, it's too fast of an activity. So what we're going to see is an increase in COMT. So an increase in, if you're normal, too fast, an increase in dopamine release. If you're variant, as with the G allele, this time we're going to see a decrease in dopamine. So what we want to start doing is looking at the relative ratio here of dopamine to the stress hormones, because we know if we clear out dopamine quickly and we clear out the stress hormones quickly, that's great for stress hormones, but not great for dopamine. The reverse side of it, if we don't clear out stress hormones quickly and we don't clear out dopamine quickly, great on the dopamine side, not so good on the stressor side. So what we see with the G allele, the variant allele, is that we're going to have that. The G is, again, the normal allele here, but it has the variant characteristics of a decreased dopamine, decreased pleasure, particularly from smaller stimuli. So again, they're looking for those bigger stimuli. But we do see decreased anxiety, OCD, and PTSD. But you've got to look at those stress genes as well. Another hormone that we have to take a look at, serotonin. We can't just blame everything on dopamine. Serotonin inhibits the expression of neuropeptide Y, and this helps to reduce hunger. So low serotonin obviously would then increase neuropeptide Y, which then stimulates ghrelin. And we just saw what happens with respect to ghrelin and dopamine and those dopaminergic pathways. But interestingly so, serotonin and dopamine are also released when we eat intense flavored foods. what happens is you get this big release of serotonin and dopamine, but it's almost a falsehood, almost like when we eat sugars and saturated fats. And it actually decreases the amount of time of satiation following the ingestion of those intense flavored foods. So now, if one codes normally for dopamine and serotonin through their genes, this effect is really quite minimal. But if they're heterozygote or variant, thus they code low for the production of these hormones and have fewer receptors, the amount of hormonal release from these foods is really high. It's just, again, as mentioned, like they're eating saturated fats or sugars. And so once again, this stimulates the same pathways in the mesolimbic systems, and it tells the amygdala and the hippocampus to value these intense flavored foods at a really high level. And that again lays that foundation for addictive behavior, food seeking, wiring behavior. And what are the genes that we want to look at here? Well, TPH2. This is the production of serotonin predominantly in the brain. TPH1 is, to a lesser degree, the production of serotonin in the bowel. And this codes for the production of an enzyme that helps to convert tryptophan into 5-HTP, again, the precursor into serotonin. And then we know that this also is involved in sleep because serotonin also gets converted into melatonin. So what do we see with the variant allele here? Well, we have a low enzyme production. So we're going to have a low serotonin production, increased risk of depression, increased risk of addictions, especially for food and alcohol, increased anxiety, difficulty sleeping, more so waking around 5 a.m. versus that cortisol 2 to 4 time, and increased muscle myalgia and fatigue. A lot of sort of IBS bloating as well with this guy. Then we have 5-HTT-LPR. This is a gene which is a serotonin transporter gene. So this is responsible for the reuptake of serotonin to plunk it into that receptor. So the normal allele is called the long version or the L side, and it's associated with normal transportation of and production of serotonin from the bowel into the blood into the receptor. The variant allele is also known as the short version or the S version, and it's associated with much less serotonin production and transportation from the bowel to the receptor. So what do we see with the G allele here? Well, we see decreased serotonin production and transportation out of the intestines to the receptor, decreased serotonin uptake, increased depression, difficulty letting go of past events. So another big one for PTSD, and this is a big one that I see frequently as a symptom with people with the variant gene here. Increased alcohol intake, cravings and binging for both alcohol and foods, and a lot of increased sugar cravings, especially for chocolate. And then we have MAOA, and this is the gene that produces the enzyme monoamine oxidase A, and this is the enzyme that's involved in breaking down or clearing out serotonin, as well as our stress hormones, and as well as a little bit of dopamine. So this is like COMT again. My favorite position for this is heterozygote because the normal position becomes too fast, which means too much clearance of serotonin, but also good because you're clearing out the stress hormones too quickly. The variant position here is going to have too slow clearance of serotonin and too slow clearance of the stress hormones. So when I talk about variants here, and you'll see this in GeneRx, sometimes the normal allele is the one with the good traits. And what I always list in my lectures or in GeneRx as the variant allele is the one that has the bad traits. So this time we're going to be, again, just like with COMT, listing the allele that is technically the normal allele, but with it this time carries the not so good traits. So the normal allele has increased enzyme production that is going to clear out the serotonin faster. So we have increased risk of binge eating and drinking, increased addictions, depression, decreased motivation, and decreased anxiety because we are clearing out those stress hormones quickly. What are some other things that dysregulate our reward pathway? Stress, absolutely, hands down, probably the number one thing. And again, you see this with patients in your practice. When stress hits, that's when they fall off the bandwagon with any sort of addictive behavior. And certainly, as we saw at the beginning of the lecture with the stats with COVID, again, shockingly, those stats, how they've risen, stress plays a huge role. But there's a difference between acute and chronic stress and how they affect reward pathways. So an acute stressor or a smaller stressor It may have a short-term addictive-like behavior, but it's not long enough to fire and wire that behavior in the brain. Chronic stress, on the other hand, greatly increases CRH production enough to start altering those pathways involved in reward, motivation, learning by reducing the amount of dopamine. So then it acts as if they are DRD2 or ANC1 variant, and we saw what that does with them. So acute stress can enhance the dopamine, but the chronic stress can inhibit the dopamine. And what are the stress genes? This is by far the most important stress gene that is out there, in my opinion. Yes, we look at the androgens and they talk about how much stress hormone you make, but FKBP5, it's a binding protein, and what it does is it makes a protein that blocks the glucocorticoid receptors on the hypothalamus and the pituitary. So we know when we have a stressor, our adrenal glands make cortisol, adrenaline, and noradrenaline. Once that stressor is over, those hormones should bind into receptors on the hypothalamus and the pituitary. And that's that signal to say to the adrenals, great, I'm done with the stressor. Tell my adrenals to stop making more stress hormone. So we initiate that negative feedback loop. We stop looping around in that HPA axis. FKBP5 makes a protein that blocks that receptor. So once a patient has released these stress hormones, what happens then is that they don't have receptors to bind into. So that patient gets stuck in that loop of chronic sympathetic stimulation, independent of whether the stressor there is over. And what do we see with the A allele or the variant allele here? We have increased production of that protein, the FKBP5 protein, loss of negative feedback in that HPA axis, so stuck in that sympathetic drive, increased anxiety, depression, increased addictions of all forms, prolonged short-term stress response, easier to get stuck in that stress loop, and increased PTSD, especially if a lot of the stressors or big stressors have happened when they were a child. We also have NR3C2. This is part of the nuclear receptor subfamily C, and it's part of the mineral corticoid receptors. So this gene basically dictates how many receptors do you have for glucocorticoids to bind into to shut that pathway off. The greater the number of receptors, the more ability we have to turn off the HPA axis and return the nervous system back to that parasympathetic side. So what do we see with the variant allele? They have really few mineral corticoid receptors, so very few spaces to turn off that HPA axis. Even worse if they're also variant or hetero for FKBP5, because whatever spaces they have, they're now blocking it with that protein. So then it just takes this tiny stressor to have this big inflated stress response and for a long period of time. So again, we see that decreased negative feedback here. We see increased ACTH, increased addictions again of all forms, anxiety, depression, hyperactivity, and ADD, ADHD. And then of course we have CRHR, corticotropin releasing hormone receptor. So this is the production of the protein that makes the receptors that bind in CRH, which then starts stimulating the HPA axis. So an increased number of receptors means an increased ability to start stimulating that HPA axis. And what do we see with that C allele? Well, increased receptors, of course. So increased binding of cortical-releasing hormone, increased addictions, increased anxiety, increased depression, panic disorders, and once again, getting stuck in that sympathetic side of the HPA axis. And of course, we also have to take a look at COMT because that's that clearing out of the stress hormones. This would be a place here now when we're talking about the stress hormones that I would prefer it all round to be the normal allele, the G allele, as the good position, because that's going to be that fast clearing out. Yes, from a dopamine point of view, it's clearing it out, but if we're talking just stress hormones here at the moment, G would be the ideal position. Otherwise, heterozygote would be. So again, the variant here would be A, decreased production of COMT enzyme, decreased clearance of those stress hormones, increased anxiety, increased PTSD, but the good news is here, we do have increased dopamine levels. Should be noted though that although the clearance of dopamine through this gene, through the A allele is slowed, so that raises dopamine levels, our stress hormones in of itself they block the production and the binding of dopamine. So it is this little bit of a catch-22 here. Other things that regulate those reward pathways, cannabis. There are tons of different genes in the endocannabinoid pathways, and they will dictate what strain of cannabis you need, the concentration, who does well with it, who doesn't do well with it, who might have side effects. And I truly feel that cannabis therapy is fantastic, but it really is a specialty unto itself. And I'm going to really date myself here. I've been in practice for, I don't know, 25, 26 years, something along that line. And this certainly was not a therapeutic agent when we were going through school. And it's not something I know a lot about, which is why it's not in GeneRx. I'm also waiting to see more research, not just on how the cannabis genes themselves dictate who will respond well and who will not, but what the effects of cannabis then do onto those same endocannabinoid genes. So once a little bit more research of that comes out too, I might take a little bit more of a peek of putting it in there. But again, therapeutically, it's something I think highly of. I'm just not comfortable prescribing it myself. But I've included it here today because THC, and a lot of our patients are on this, it stimulates the release of dopamine, but it does so by increasing spontaneous firing in the reward pathways and increased bursting rates of dopamine in the VTA. So the long-term effect of that is altered pathways so much that there's a significant increased risk of substance abuse disorder. So much that it's actually 48% of those who use cannabis daily always progress on to a more illicit drug use. So that's pretty significant. And the reason because of this is because what happens is that increased firing and bursting down those reward pathways, it impairs the plasticity in the hippocampus, which creates irreversible changes. And that should be really noticed here, irreversible changes in focus, concentration, and motivation. And as soon as we start to lower our motivation, well, we know how that then goes into all of our addictive behaviors here. So this is still, again, something I think we need a lot more research on, but I think it's also just important to take note of it when we're looking at addictive behaviors with our patients, again, because so many people are using it. This is also to note that this isn't just the cannabis oil, this is specifically the THC. Other stimulants that dysregulate our pathways. Cocaine, alcohol, nicotine, they reduce dopamine receptor availability. So essentially, what these guys will do is inflame the dopamine receptors, making them or rendering them pretty much inactive. So we can pretty much treat that patient as if they were DRD2 or ANK1 heterozygote or variant, just literally having less receptors. Alcohol also decreases the production directly of serotonin through the TPH2 gene. And this is independent of how they code for it. It's just obviously significantly worse if they're heterozygote or variant. And ironically, this increases the antisocial alcoholism, not the social alcoholism, not the sort of fun drunk, but the one who's hiding it in their room or sneaking the alcohol. And there's a reason why alcoholics often smoke, or smokers often do it while they're drinking alcohol, because they potentiate each other's reward effects, so they're getting a bigger high off of it. Some less serious addictions, but I really wouldn't call these less serious, because again, as we saw, 47% of adults are eating uncontrollably since the start of COVID, and that is, as we all know, that's going to go down into a whole other pathway of different diseases and ailments. But food, especially the highly palatable foods, the ones that are high in carbohydrates and fats and salts and sugars and artificial sweeteners, they trigger the VTA to release dopamine and serotonin. But they get a very similar effect, just as what we saw with the intense flavored foods. So they get a much bigger high, bigger release of serotonin and dopamine from them, but a shorter satiation period for them. So those receptors become empty once again, and then those receptors are looking to be filled back up again, and that starts triggering that whole food-seeking behavior that we saw in that cycle at the beginning. Junk food, though, has an even worse effect. It's more powerful. And what it does is it works through the AMPA receptors. So motivational responses are mediated in part by AMPA receptors in the nucleus accumbens. And junk food really increases the sensitivity and the responsivity of these receptors. And in fact, just eating junk food once can increase the responsivity and sensitivity of these receptors for several weeks afterwards. That's how sensitive these receptors become after eating junk food, particularly when compared to whole foods. This was thought to be an evolutionary adaptation to motivate one to go seek out these more palatable foods or highly caloric foods during times of famine. But we now know that we're never really in a famine anymore. And this responsivity or sensitivity is so high that when rats who are given junk food and exposed to junk food, even when they were exposed to junk food and they got a foot shock every single time they went after the junk food, they will still every single time go after that junk food. That's pretty powerful to accept a foot shock just to get a little bit of junk food. And ghrelin, we saw a little bit of this before. Increased ghrelin, as we know, stimulates that food-seeking behavior. But what's really interesting, particularly when ghrelin is really high, particularly in MC4R and FTO, it will override leptin. So we know that ghrelin is our hunger, food-seeking behavior hormone. Leptin is our satiation, I'm done, I'm satisfied hormone. But ghrelin will always take precedence. So if we have a higher ghrelin, particularly with a lower dopamine, because again, we saw how those two augment one another, even if leptin is normal, it's going to override it. You may have just have eaten, you're still going to be going back to the cupboard. Ghrelin receptors are also expressed all the way through the VTA and the mesolimbic area, and this is how they stimulate all those dopaminergic pathways. And of course, all of this is worsened with increased CRH and increased stress. So what are the genes that we're talking about when we look at these last few genes, last hormone, ghrelin? FTO for sure. FTO regulates ghrelin, leptin, and adiponectin. It can stimulate all dopaminergic pathways in the VTA, and it increases that synaptic firing and wiring really quickly for food-seeking behavior. The A allele, the variant allele, has a much lower metabolic rate, really high incidence of food addictions or addictions in general, increased risk of obesity by 1.7%, increased adipogenesis. So that has those two hormones, IRX3 and IRX5, which will convert immature fat cells into white adipose cells as opposed to brown thermogenic fat. And then all gene expression with this, the increase in the A allele, is turned on when eating saturated foods or simple carbohydrates, sugars, or even just increased caloric intake, even if it's healthy caloric intake. And ironically, these are the exact foods that the FTO-A allele craves. They crave the saturated fats, the sweets, and high volume of food, which then just triggers it further around. MC4R, melanocortin-4 receptor in the hypothalamus. And again, this regulates ghrelin versus leptin, so satiety versus hunger. And as we saw, ghrelin increases neuropeptide Y and AGRP, agouti-related peptide hormone, which then increases hunger and stimulates those whole pathways. Leptin, on the other hand, increases alpha MSH, which inhibits neuropeptide Y, which is what we also saw serotonin do, which increases satiety. But if we are variant here, we're going to have a much higher level of ghrelin, and that's going to override anything. Even being heterozygote for this gene increases obesity and BMI by 8%. If you're variant, it increases it by 43%. And this is entirely independent of diet and exercise. These are the patients that really, really need the hormonal support here. We're going to have increased food addictions, increased insulin resistance by 14%, especially with sugars and saturated fats. And the variants here are the ones that have a lot of increased weight gain with antidepressants or antipsychotics. So let's look at some case studies here and look at the comparison of case studies. And it'll show us how knowing exactly what is going on in terms of what's behind the addiction helps us treat that addiction, and how we really can't just look at two people who might be addicted to the same or a different substance and throw them just on dopamine support or throw them on the same program. So Mark is a 26-year-old male who describes himself as an all or nothing person. He's very competitive. He's a competitive athlete, and he always pushes himself. He said he pushes himself in school. He pushed himself in work. In everything he does, he pushes himself to excel. He said he usually thrives under stress, but more recently, his stress levels went so high that he pushed himself into exercising so much that he threw himself into overtraining syndrome from it. He was then instructed not to work out for 3 months. And then after that, because he wasn't working out, he found himself so unmotivated because his dopamine just started to plummet. He didn't want to work. He didn't want to see his friends. He started drinking, eating potato chips, all those dopamine foods, and he gained 14 pounds in 8 weeks. So if we look at Mark's genotyping, his DRD2 and his ANK1, both heterozygote. So not variant, but hetero. And he has so less dopamine production, less dopamine receptors. His COMT is normal, so his fast clearance of dopamine, but also fast clearance of the stress hormones, so that's good. FKBP5 variant. So again, we have that protein blocking those glucocorticoid receptors. So we have a really easy increased loss of negative feedback in that HPA. His CRHR1 is heterozygote. So again, a little bit more cortical-releasing hormone receptors stimulating that HPA axis. His FTO was variant, so big increase in ghrelin, especially when not following the genetic diet. And MC4R, his ghrelin here was normal. Again, just to remember, FTO can really moderate itself with diet. MC4R, not so much so. So that's just something to keep in mind too, in the back of your head when we're looking at our patients and their genes. So what does all that mean in terms of his genes? Well, from a young age, Mark, despite the fact that he had lower dopamine coding, he kept his dopamine high by pushing himself through competitive sports and, quote, competitive academics, meaning just pushing himself through school and work, etc. And dopamine is really produced when you start going after something. It's actually less produced when you achieve that something, because as soon as you achieve it, the dopamine then goes down and it stimulates that behavior to want it again. Hence the addiction with drugs. You use going after the drugs, they get the high, they take the drugs, then it drops down and they want that high again to go after it. So he had kept that dopamine high. And once you start on a positive dopamine pathway with behavior, that in of itself keeps the dopamine high enough that it keeps you motivated to keep doing that. And we all know a perfect example of this is once you sort of get through the first couple of weeks of starting exercise, then you start to become addicted to it and actually crave it. He had also kept his FTO gene in its off position. So remember, he was variant for that. So slower metabolism, but because of his sports, he had always eaten a really clean diet. Then the stress of work and life started. And this is where he went, oh my God, I'm going to start exercising more and more and more because that's always been my amazing coping mechanism for stress. But this amount of stress at work and this amount of exercise was too much for his body. So it triggered his FKBP5 to make that protein to go block all of his receptors. His NR3C2, he was heterozygote. I didn't put that in the list because the list can become too long if we look at every single gene. So again, this is a really easy way to push somebody into overtraining syndrome or adrenal fatigue. When we see hetero or variant for FKBP5 and NR3C2, so easy to slip to that hypoadrenal side, or if they're physically strong, stay up in that hyper side for quite a while. The inability to exercise triggered all of his dopamine genes because he had no form of dopamine coming in. So his brain was looking for the dopamine. So what did he do? He turned to that alcohol and the potato chips. The alcohol and the potato chips then triggered his FTO genes, which were all off before. So if we look at his dopamine genes were turned off before, his FTO genes were turned off before, and his stress genes were turned off before, all because of clean lifestyle and exercise. But then stress hit his body too much. He maladapted to it. And then the stress of that just started triggering everything. Once his dopamine and FTO genes dropped, then that further increased his stress genes, and the cycle goes around. So what do we do with Mark? Well, I put him on Focus Plus, 2 capsules twice a day, empty stomach, only until he could exercise again. Put him on Serotonin Plus because we need to reset that HPA axis. So 2 caps twice a day, empty stomach. Again, I did it until he could exercise. Then I lowered him to 1 twice a day, and then kept checking his orthostatic BP. Put him on Adrenal Plus because he was definitely in the hypo condition, and kept him on 1 BID until his orthostatic BP was plus 10 again. Then I reduced him to 1 a day for 3 weeks and then off. Put him on TMC, so that's to regulate out the leptin and the ghrelin. Does do adiponectin as well, but his was okay. 2 caps twice a day, 30 minutes before his 2 meals for 8 weeks, and then rotated it in 1 week out of every 5 weeks. So once you reset the FTO gene or an MC4R gene with TMC, unless they're perfect with diet and stress is not an issue, and that's really hard to do, generally those genes are going to undo themselves. So particularly as we age, when we're younger, our stressors are a little bit smaller, our body's a little bit more resilient, and those genes have a tougher time turning themselves on. But once we sort of start aging, that's not quite the case. So by rotating TMC in 1 week out of every sort of 4 to 6 weeks, and for him I chose 5 weeks because of his symptomatology, and I'll explain that in a second. It's a way of saying, don't even think about undoing FTO or MC4R. I know life is tough, and you just need that 1 week of taking it 2 caps twice a day. Then you can stop it again for another month. Whether I put this in at 3 weeks or 4 weeks or 5 weeks or 6 weeks is really dependent on the patient's symptoms. So what I do is at the end of the 8 weeks, I generally stop it with them. And I ask them to watch for symptoms of food cravings or possibly weight gain or any of those leptin, ghrelin, adiponectin symptoms that we might see. And even if they start thinking about that behavior but don't actually go for it, that's when I'm going to say to them, okay, that's when I want you to institute it. And we might find that that happens every 3.5 weeks, or it happens every 6 weeks. Some people push it to 2 months. So it is individual and you can play with it. If that's too difficult for a patient to decipher, then I usually make it fairly easy for them. Take 1 month off, take it for a week. Take 1 month off, take it for a week. Moved him to intermittent fasting style because of his FTO, and he increased his protein. Reduced his saturated fats to 22 grams per day because he was also variant for his ApoA2 gene. Reduced his carbohydrates ever so slightly with TCF7L2 because he was hetero for TCF7L2 and GIPR. He was normal for his IRS1. And then I sent him again, because he's a very regimented guy, to get a menu created according to his genes with Feed Your Genes. I don't know if you know feedyourgenes.ca. It's a fantastic website that you can go to by Morgan Canal, and she can really create and design individualized menus and dietary programs to genetics. So it's fantastic. The other thing I had him do is increase or create mini challenges once a week, or mini goals. Dopamine is all about going after something. Dopamine loves new because new means a new challenge. It means a new learning, a new direction. That's what dopamine loves. Dopamine hates this. It hates the same. So each week, it could be as small as when he, went out to exercise, he went down a different street, or it could be as large as learning a new language. It could be anything, but it had to be some mini challenge every week to sort of spike up that dopamine. Within a week, his desire to eat fatty foods and drink alcohol reduced by 40%. At the end of the first month, his energy started to return, especially after walks when he used to be really exhausted. And his motivation was returning, but not back to his norm. By the end of the 3rd month, he started running 5Ks, and he started feeling great. And that's a pretty fast production of results in terms of getting back to exercise with overtraining syndrome, if you've ever had patients with that. By the end of the 4th month, he was consistently running 10 to 15 kilometers. 3 times a week, he had lost 12 pounds and was starting to feel inspired again. So by the end of the 6th month, he was off the Adrenal Plus and off the Focus Plus. We maintained the Serotonin Plus at 1 twice a day. And even when he cheated on his diet, he found that it no longer spiraled him down into that series of cravings. On the other hand, let's look at Annie. Annie's a 53-year-old female. That should say old there, not odd, who has always been troubled. That was her word, not mine. She started drinking at a really young age, and she would go into depressive bouts before and after drinking and slowly shut out the world. She went to Alcoholics Anonymous successfully, and she no longer drinks, but she pretty much just shifted that behavior into eating carbohydrates obsessively. She tried to go to Overeating Anonymous, but it didn't work for her because she still couldn't control her binges. So her GP put her on Celexa, and it did help curb some of the cravings a bit. But once she took that one bite of a trigger food, she just couldn't stop it. So if we look at her genes, her dopamine is far worse than Mark's was. She's variant for both DRD2 and ANK1. So she makes much, much less dopamine and has much fewer receptors. She's a heterozygote for her COMT, so she clears out the dopamine a little bit faster than I would like, but she's also not clearing out the stress hormones as slowly as I would want. So again, that is kind of that Goldilocks gene there. Her serotonin, her TPH2 production, serotonin production was heterozygote, so less serotonin production. But her 5-HTTL-PR variant. So despite the fact that she was making serotonin, she couldn't get it out of the bowel into the blood, into the receptor. And if it does get into the receptor, then as we know, it really doesn't matter. Her MAOA was heterozygote. So again, a bit faster clearance than I would want for serotonin, but also and a slower catecholamine clearance than I would want, but at least it's not the slowest position for catecholamines. And here she had a higher ghrelin, not her FTO was actually normal, but she had a higher ghrelin through her MC4R. So what's going on with Annie here? Genetically, she has really poor dopamine, much lower than Mark, and she does have low serotonin. But again, the bigger variable here was very poor serotonin transportation, which is why the Celexa didn't fully help there. She didn't exercise as a child. So unfortunately, unlike Mark, who sort of went into a good addictive behavior, which boosted his dopamine in a healthy way, she didn't. She started drinking. And then that triggered off her dopamine and serotonin genes, and then all of the addictive behavior. The Alcoholics Anonymous and the Overeating Anonymous, they didn't address these hormonal sides of things, which is why they never really worked for her. So what do we do here? We use the Focus Plus again, twice a day, empty stomach. Kept her on the Celexa at the same dose. Put her on the TMC to help control that ghrelin, that food seeking, but any form of seeking behavior. Twice a day, 30 minutes for 2 months. And then I used it once every other day for her thereafter, and I'll explain that one afterwards. Also had her doing 30-minute walks in the morning as much as she could. Annie reduced her binge eating by 30% in the first month. She reported her mood started to lift and she started engaging with friends and family again. By the end of the third month, she was ready to transition from Celexa to Seroplus and did so successfully. We put her on 2 caps twice a day. 9 months later, she was not binged in 3 months. And then she tried to reduce her Focus Plus and her Seroplus down to just 2 a day. But within 10 days, she started binging again. 2 years later, she remains on both Focus Plus and Seroplus. We have weaned her off of the TMC here, and when a craving hits, she's able to redirect her behavior. The reason I initially put her on every other day of TMC after that first stint was because ghrelin really fires and wires that food-seeking or addictive substance-seeking behavior into the brain, and it doesn't really respond well with dietary changes. I wanted her to have a higher hit daily or every other day of lowering that ghrelin, because ghrelin and dopamine, as we saw at the beginning of the lecture, augment each other's addictive behaviors. So if we can get that hit a little bit more frequently, it worked much faster for her. So when we look at the difference between these two, Mark's issue was dopamine and stress, but less dopamine, a lot of stress, compounded with really high ghrelin, whereas hers was really low dopamine and serotonin, not so much the stress, and moderate ghrelin. Mark was able to control his dopamine long-term through exercise, but Annie requires the Focus Plus and the Seroplus to keep her genes stable. Mark was able to control ghrelin by a clean diet and rotating the TMC, whereas her control of ghrelin, the MC4, are less responsive, and that's why we had to do that half dose. We did that for about 2 months, and then we started to wean her off of it. Mark requires the Serotonin Plus to keep his dopamine genes, which are less variant than Annie's, in a good place. So as long as he keeps the stress pathways fine, he can control his food, he can control his dopamine through the DRD2 and FTO genes. Whereas Annie, her stress genes were not the issue. It definitely is the dopamine serotonin side of it. And because she wasn't an exerciser, and as much as I tried to push her down that route, she didn't want to go down that route. She requires the Focus Plus and the Sero Plus, but she doesn't require the stress support. So you can see these are two cases where there is addiction clearly on both sides. The behavior sort of spiraled down, for both of them. They were both got to a place where they were drinking and eating. They were withdrawn from life, but their treatments are completely different. And if I had given, if I'd given them each other's treatments, particularly if I'd given Mark because his serotonin genes were normal, Sero Plus or anything like that, could have easily thrown him into serotonin syndrome. But at the same time, if we didn't treat the ghrelin side for Annie, she never would have got to lower the addictive behavior by the accumulation of the ghrelin and the dopamine together. So they're very, very different. And again, this is why I love genetics, because it allows me to see where things are coming from, and then allows us to help better direct our patients. So I open things up. I think we have just under 15 minutes left, but I open things up to any questions. Please feel free to type away in the chat room if you have any. Are there any contraindications for Focus Plus? Yes, there are. Very good question. So Focus Plus contains something called rhodiola, and rhodiola will crash COMT. And so if somebody is too slow for COMT, so they're not clearing out their dopamine and they're not clearing out their stress hormones, and you give them Focus Plus, you're going to crash that gene even further, which means it's fine from a dopamine point of view, but you're going to really increase the amount of stress hormones through the body, so you can increase the anxiety. So that's a place where I will often turn to just a straight tyrosine as a dopamine booster, or anything along that line. Back orders. Oh my God, shoot me now. And Happy New Year, Lisa. God, the back orders are killing me. So I actually have a full list from Atrium of all of the products that are on back order and when their scheduled dates are to come back in, because I was literally pulling my hair out with all of this. So if anybody wants that list, just email me and I'll shoot you off the Excel spreadsheet. Just email me at the end of the lecture or at some point today in the next couple of days. I'm very happy to give you. So at least you can see what's in stock. In terms of Sero Plus, what I'm using instead is 5-HTP Plus by Douglas, or just straight 5-HTP from Pure Encapsulations, or 5-HTP Supreme from Designs for Health. Focus Plus, for anybody who is, I don't know if anybody's listening from the US, I know there's a couple of people who requested the lecture from the US. They have, Designs for Health has something called Dopa Boost, but it's only available in the US. Otherwise, right now I'm just using like a tyrosine-based formula, because they are so often on back order. Absolutely, I'm happy to send out that list again if you can, because I'll forget by the end of the lecture. Just email me, and I'm really happy to email it to you. Can you give an idea of guidance, things to keep in mind for weaning off? Absolutely. So when I first put somebody on or start to wean them off of an antidepressant, I will keep them on the exact same dose of antidepressant and then put in the Sero Plus or 5-HTP Plus or whatever we're using at the moment. Because there's going to be a receptor competition. Sometimes the antidepressant is going to win, the pharmaceutical. Sometimes the Sero Plus is going to win. This one doesn't have quite a strong affinity, but as we know, it teaches the body to start making more of its own serotonin and start upping it into that receptor on its own. So when we start doing that, you actually start to lower the efficacy of the antidepressant. So I'll do that usually for about 2 weeks. And then I start to drop the dose of the antidepressant either by a third or by a half. So going every other day, half dose every day, or 2/3 of a dose every day, that sort of thing. Really key though, don't ever try to take someone off of an antidepressant unless you fix their adrenals or their stress genes. That's just a recipe waiting to backfire on you, because The cortisol, as we know, is going to stop the body's binding of the antidepressant or the seroplus or the production of our own serotonin. So fix those guys simultaneously, whether it's serotonin plus, serotonin and adrenal, if they're in the hypo state, adrenal plus, that sort of a thing. But really good question. And again, really make sure that you address the stress hormone side of that too. Are there any other questions? How do you use? Absolutely. So this is actually my go-to for a stress hormone response, for a couple of reasons. It's orthostatic blood pressure. The Dutch test, one, it's expensive. Genetics are expensive. Product is expensive. So I'm going to look at what's going to get, what can I get the most out of? And in my opinion, I get so much more out of genetics than I would get out of just a Dutch test, or any hormonal panel, because I can see the pathways of all the hormones, not just like that one pinpoint moment in time, what's it doing? So I'd rather do a free test in office to test the stress response and then allow them to do genetics or byproduct. Orthostatic blood pressure, when they're lying down, have them lie down for 5 minutes, take their blood pressure, have them stand up, wait 1 minute, take their blood pressure. I usually have them stand up, take it right away, wait 1 minute, take it again, and compare. When we stand up, gravity pulls blood away from the head. That acts as a physical stressor. So our adrenal glands pump out adrenaline, noradrenaline, and cortisol, tightens up our blood vessels, pushing blood and oxygen up to our head. And that's our mechanism of how we don't faint every time we stand up. But we just need a little bit of stress hormone to do that. So when we stand up, the blood pressure, both systolic and diastolic, should go up 10 points and only 10. And that's a perfect position for the adrenal response. If it goes up too much, they're making too much adrenaline, noradrenaline, and cortisol. It's hyperadrenal. If it falls rather than going up 10, it's very little adrenaline, noradrenaline, which are the vasoconstricting, still too much cortisol, vasodilating, and that's the picture for hypoadrenal. When we do this, it is not just what's happening in that stress response here and now. It's how the hypothalamus is interacting with the adrenal, so that HPA axis for the last 6 weeks. It's kind of like fasting glucose versus hemoglobin A1C. The lying down blood sugar is like the fasting lying down blood pressure is like the fasting glucose. The standing up is like the hemoglobin A1C. So it gives you a good look at what's going on in a broader period of time versus just a one-off moment. How do we slow a normal COMT or MAOA? So you can slow a COMT with straight rhodiola. That will crash the COMT and slow it. So it becomes a catch-22 again. So you really have to look at the stress genes here, because do you really want to slow it and then keep more stress hormones in them? Now, if they code normally for all their stress genes, absolutely, it's a great tactic to do. Use rhodiola. Rhodiola will crash both MAOA and COMT. But make sure you're always looking at where the stress genes are, because if they're variant and then you slow that down, I think the stress hormones have a more powerful effect of having too much of those than trying to get at dopamine by slowing the COMT, or serotonin by the MAOA. What are you substituting for serotonin plus? God, I know. I'm not, unfortunately. I continue to look for substances that will reset the hypothalamic and pituitary receptors versus just decreasing cortisol response or decreasing slowing sympathetic drive. And this still remains the only one without side effects that will get the patient back to parasympathetic. I fortuitously caught wind that it was going on back order, so I did buy a bunch. So if anybody lives in Ontario and they're desperate for some, I do have some at my office. So I'm fortuitously not in that position right now. I don't have a good answer for that. I mean, you could use cortisol manager by enzymatic therapeutics, but you could use all of our adaptogenic herbs, but they're just slowing the sympathetic drive. They're not getting them back to the parasympathetic. So it's a tough one. However, when I did look on the sheet of when serotonin is coming back, I think I saw it's coming back in February. So it's not too long now. And I think it's just the pure encapsulations version, the larger bottle, not the Douglas Labs version, but I mean, it's the same thing anyways. What are the common mutations you see with yo-yo dieters who struggle? Absolutely. Biggest yo-yo dieter ones are the AdipoQ. particularly the adipaq that codes for what happens when they cheat. So adipaq is the gene which codes for adiponectin, which regulates blood sugar levels, fatty acid oxidation, etc. And those who, when they cheat, they produce a really low level of adiponectin. They're the ones that rebound up really quickly in weight. And then as soon as they get back on their genetic diet, they drop the weight quickly. And then if they cheat again, it goes back up. But FTO and MC4R are also huge variables with that because of the ghrelin and the leptin that are there too. So that's a big one there. Any other questions? We only have a couple of minutes here, but I'm happy to answer anything. I thank everybody for taking the time. I know everybody's just getting back, from the New Year's, getting back into the year, whatever this year is going to bring. I certainly hope it brings everybody health and happiness for sure. If you do want that Excel spreadsheet, just please email me. And you can also let me know about if you are more interested in just getting these lectures online versus having them live, because a lot of people have expressed that just from a time point of view, and gosh, I certainly understand that, then I can also do that. I do have also a series of genetic courses that are online that you can go on to GeneRx.ca. You can also go on to PKR health.ca, my two websites, and you'll see a link to them. And these are CE credited courses. So they're online, you can get them, and you can get your continuing education credits for them. So please help yourself to those as well. And thank you so much for joining everything today. I will reformat the lecture, and I will get everybody a copy of that later on this afternoon or this evening. And once again, I thank you all for joining. Bye, guys. Thank you so much.